Positioning. Always, so supine position. Here we go. Yeah, jaw alignment. No wonder you got TMJ. I'm sorry. Referral. not my fault. Always have they already had the pillow there for them in sideline, but just always have the pillow there. Okay, you may have to make it smaller. You don't want them like that. And then bolsters under the knees. As a general hack in general, the roundish ones, this is a little bit too thin. The larger, rounder ones are preferable. But if you want it to be hitting a lot of marks all at once, even for like fluid movement, lymph drain stuff, that's where you keep that square bolster as part of this.
You use both?
Just put both. The square one needs to be closer to the ankles, and do you have another round one? Throw me one. The other round one goes underneath the knees. Or two square ones, all that good stuff. You're the best, thank you. This is why I don't like these. When I find these, if I can find a second one, I tape them together. That's what I should be doing with these. I tape two together, make one round one. But here, talk about a way to take any stress off of the low back, pelvis, and hip, and to assist fluid movement. Done. Manual lymph drain, done. Circulation support, done. Positional release related to taking all of these structures of the skeleton and joints and putting them in a loose pack position. Now, as they lay here, the therapy is happening. And I could just go about the massage and see if putting them in this ease position is helpful all by itself. So that would be maybe the first thing to do. This doesn't change my ability to work here, all that good stuff. But once we get to, let me come all the way back up to the head. Usually my routines would follow general squash, and the interventions would get thrown in at the end of each position. So a person's laying in prone, I would do the massage routine in prone, and then if it's low back, for example, go do some inhibitory pressure, activate the opposite glute, go to the other side, do the same thing, balance them out. Now I've already made you move, time for you to turn on your side, massage and side lying. Then I would do those interventions actually as they were convenient. When I'm at the neck, do the suboccipitals, at the low back, get quadratus lumborum, all of that. Side, balance them out. Supine, now it's time for relaxation. Just wrap everything up. Usually it's not very long, but at the end of the massage is then where I go like, all right, it's gonna be really time to wake up. This helps in terms of routine. Sadly, sometimes we're looking at the clock and we're like, I really feel like I should put you through both, but we only have time for one. So, we're here, we wrapped up everything. Frontalis, frontalis, turn the head. Occipitals, not suboccipitals. Frontalis, occipitals, temporalis, temporalis. Wow. Please, if you can, save your fingers with all of this stuff and do it in sideline. That way you can do all this finger point pressure in supine, and it's just to make it feel good and balanced. And maybe I find a tiny thing where I target and have a person do some movements and stuff. But if you can take a bulk of the work there and do it in sideline, you save your hands an enormous amount of effort, because this is where therapists hurt themselves like crazy. All right? Now, sternocleidomastoid, here to there. This is the position that we'll use for that. And I have a way of making it as friendly as it possibly can be. One, it's a neck flexor, so we put the head in flexion. I'll put the pillow always there for both sternocleidomastoid and scalenes. I always just put the pillow there to make it safer, more comfortable. I turn the head a little bit. When I have a person here, you'll really see that kick on when they lift their head up like this. And then instead of pinching it with a thumb, I go, time for a clam. Broaden out the compression on both sides. It's way less ouchy. Can you believe it? So one side at a time instead of both sides together. This is how I got taught it, is just come in and go, ah, you know, clamps. It's more intense. It's more time efficient because you get both sides. But I think it's worthwhile to just, nicer to your hands, nicer to them. And usually one's worse than the other anyway. Scalenes and pectoralis minor, that's why I sprinkled pec minor in there. Thoracic outlet syndrome and brachial plexus impingement, same thing. But those nerves have to escape from the cervical spine and get underneath the clavicle. They are kind of underneath and have to go through those little scalene muscles. The scalenes, remember, are on the lower cervical vertebrae and attach on the first two ribs. So they're low. They're not up here. You're not doing a scalene release up here. You're here. Okay, they're bandy. This is the one you got to be ultra careful of. If you feel a pulse, don't do that. If you push and you create a nerve zing, don't do that. Maybe just don't do it. But my application point, I usually find the clavicle and search for that first rib. Then I'll come up here on the neck, start, safer and easier to find it here. Find the clavicle, come down, approximate, have them laterally flex their head, and or take a really good deep breath because it attaches onto the first rib. When I take a deep breath, I'll feel a kick on. Then I know I'm on the thing. Wow, it's not so bad, but not up here going, gah. Start down here where you can't miss and there isn't as much of a delicate tube to worry about. But scalenes are notorious for being a part of, if not sometimes the cause of the impingement syndrome. It's sometimes thoracic outlet, brachial plexus stuff. The main causal element can be that the scalenes are actually pinching those nerves. The most common one is pectoralis minor. So coracoid process and pec minor way underneath pec major. So find that divot between deltoid and pec right here, right? You got to go a little bit higher than that. Find the clavicle, trace your clavicle, find a divot. And it's somewhere around there, but you got to track towards the ribs on an angle, inferior and medial. So I can't be up here and go, I'm going to be on pec minor. I have to find it and then orient myself with the muscle. It attaches from this point and splays out and goes on to a few ribs. So I just stand directed across the body at an angle, and that's how I get to pec minor. Pec minor, those nerves have to go underneath the clavicle and underneath pec minor in order to get down your arm. It's a crazy series of tunnels they have to navigate. So scalenes, pec minor, related to weird nerve stuff down the arm. It's worth considering. Even if it's not the source of the problem, those commonly will become part of the symptom as the body adapts. So pec minor is initially easier to find, but consider both. That's where you can be a real magician with this stuff. So can do finger point, focus. Can do soft fist, focus. My favorite, forearm. Just don't smash a clavicle. That's all right. If you have to, one of my things has always been put your fingers down, put your olecranon as your starting point there, and then flatten your forearm out from there. So my fingertips go where I want my application to start, and I remove my hand, and I can replace it with the forearm. Subscapularis. This thing can be a big part of it. Serratus anterior is that big one that sits right here. You'll see it in pictures, right? Look, big bodybuilders, all that. It is a scapular protractor. Thus, when we see somebody laying on the table and that scapula is elevated and protracted, Subscapularis is the direct antagonist to infraspinatus. So the rotator cuff group, supraspinatus, infraspinatus, teres minor, and then subscapularis on the interior side of the scapula. People are scared of this one, but it's because they just go after the armpit. Don't do that. We just talked about all these tubes. So if we're going to interface with these things for the first time, and I'm mostly convinced that a big part of what we do when we come into this space is we're separating subscapularis from serratus anterior. I don't always think it's as much about changing the strength and tone of these muscles, but they love to get glued together, especially when the arm, after injury, puts itself or is artificially put into a sling-like position and held there for a long time. What does that do to my scapula? I'm internally rotated, that's subscapularis for the glenohumeral joint, and then the scapula tends to elevate and protract. And then everything just glues down in that position. So, why go after the scariest part of this to start with? Just find the lowest part. Look for that inferior angle and work on that first and see if it even helps before, and I mean, that's it for one session. Then maybe after a while start challenging it and go higher and deeper. And if you're gonna do it, you gotta make it, because you have to get in between. Subscap is on the interior surface of the scapula. So, if I have a person laying like this, where their scapula is retracted, is that gonna make it easier? No. So the fancy positioning to just make this more accessible is, here's your arm client. I put them in a sling. And that will naturally pull that into a protracted state, making it easier for me to even find it, and especially easier for me to get in between the scapula and the ribs. Really super cool part about this too, where I feel proud of myself, is FaceTime video, is if subscapularis is an internal shoulder rotator, I have them positioned like this. All I have to ask them to do for the muscle entry technique is push their hand into their chest. So I position them like this, and I say push your hand down into your chest, and that will activate subscapularis. And then I can get that to free up ideally. Positioning's here, and then with their arm like this, it actually shields me from getting the armpit. So I just hold on to their elbow, and I search for the lower aspect of the scapula. And that's where I try to put my fingers. And the thing is, this is hard on your hands. This one and psoas are hard on your hands. So if you're gonna do these, this is where you save your fingers, because there's no other way to get here. And that's a journey. So that's the positioning. Just put them there, put them in the sling, have them guard their armpit so you can't get there, and free up this part of the scapula and subscapularis and the inferior aspect first. You can go further with this, like pushing here and having a person reach for the ceiling and really shearing that connective tissue and getting that to release. But that is quite uncomfortable. I will just say outright, this consistently is the most ouchy of the releases I could ever show you. there's gonna be some people that are unique and some people that are just made of, you know, hardened, hardcore awesomeness. But this is the one that tends to be the most brutal. And if you're gonna do it though, make it count. Just be too scared and only like stab serratus anterior. I mean, if you're gonna do it, make it count. Or don't do it. For psoas, always knees flexed, feet flat, always. Eventually, you know, break all these rules all you want, that's fine. But if you want the safest possible option, it's put them like this. And why it always synchronized well with either the beginning of supine, but for me, usually the end of supine, because I could remove the bolsters, get them situated like this. And now from this position, I'm set up to do the pelvic girdle assessment, see if they're crooked here, and all that good stuff. We'll look at that more, but it's just getting your thumbs on the AS, IS, anterior superior iliac spine, compare and contrast. I tend to assume the one that's lower, tipped down, is the wrong one. That tends to correlate more often than the other as the symptomatic side. That the hip pelvis that is anteriorly tipped, meaning when I'm looking at my thumbs, the thumb that's lower tends to be the bad one. And I always walk around the other side of the table. Can I hold them? That was great. And compare and contrast to make sure that I'm not getting an off read. Part of this too, that I forgot, is prior to that assessment, asking them, we take the bolster out, asking them to pick their hips up and set themselves down more symmetrically. Because you don't want them laying there inadvertently crooked. So they just gotta pick themselves up just a tiny bit. And then I get their feet, I always grab their feet and ankles like this, make sure their feet are symmetrical, and then I can get as accurate an assessment as I possibly can. Now, this is where, for these fancy releases, just like I said for subscap, you want to make it less ouchy and super safe, sling, inferior aspect of it. For psoas, is huge, and it is a crazy muscle. It does a lot of cool things, but it's also, you know, a villain in a lot of the low back symptom stuff. When the spine is fixed, it's more about hip flexion. It is the first and most dominant of your first movements of your leg forward as you walk. If the hips are fixed and I'm just standing there and this contracts, it pulls the spine down into the pelvis. And one of the worst things that it'll do, if it gets really strong and starts winning, if there's weakness and there's some kind of just odd asymmetry here, person stands with their hips flexed, and then they let their core is weak and their glutes are weak. So their spine muscles, including psoas, contract, and they pull the spine down, but that also increases lordosis. So that lumbar curve gets exaggerated. Thus, the assessments for a tight psoas tend to be seeing if that lumbar curve is exaggerated. Person stands, it's like this, right? If more precisely, I put them in this position with the knees flexed, feet flat, and I can fit my hand underneath, that means their lumbar spine is stuck in extension, meaning psoas is almost certainly the culprit. So if you want the clearest assessment, that's one of the best ones. You get them here, and then, whoop, wow. Yeah, psoas is part of this problem. So that's the assessment. Now, I move everything around. Yeah. The safest access point for this, though, is It confuses me. Anybody out there just using their thumbs and curling in like this, you're driving me crazy, and stop it. It's not a psoas release, it's an iliacus release. Iliacus and psoas do come together on the lesser trochanter, so interfacing with this may help some, but you can just curl in. It is an option to just come over to the pelvis, curl your fingers over, and you're going right down on top of that. So, does that tend to be as much of an issue? No, because this only functions at the hip. Only psoas also works at the lumbar spine. So, where this gets taught and made more scary is people will draw a line from the ASIS to the belly button and say go straight in the middle, right? Now that's where the belly of the muscle is. I get that that's where we want to get. But to start with, for the comfort of your hands, your brain, and your client, starting lower at the edge of the pelvis and letting that guide you over and getting this lower inferior part, it's just so much easier and it's the better place to start. So I get a person here, and laying, he's flexed, feet flat. All I have to do is find the ASIS. I already looked at it from here. I find that, I come over and I stay where I feel the edge of the pelvis against my hand. That'll keep me from going somewhere I'm not supposed to. I stay here. Now if I curl in too sharp, like a claw, I'm going to get on iliacus. That's not what I'm looking for. I come in and I go on an angle toward the spine, about a 45-degree angle. But the whole time, I can feel the edge of the pelvis, and that's helping guide me and stabilize my hands. So I find here, curl over, go in. And always muscle test. So I have them just lift their knee up toward me a little bit. That'll kick on, and I go, ah! And I know I'm on it, and then we begin our journey. From this position, there's a whole myriad of muscle-led techniques and things to be done. I mentioned before, the most aggressive one will be I pin this and have a person take their leg down into full extension and fire the glutes. That's a really aggressive way of intervening, but it does work. I'm going to start you out with a way that I feel is best on your hands and body mechanics, and also gives the client a level of control so that they can either lean into your pressure or run away from you. One of my philosophies related to psoas being a big part of this problem is this muscle, when it's super tight, the way I think about it is it locks you into the sagittal plane and starts inhibiting rotation. So it's just inhibiting, this is kind of just like holding everything really still and vertical, and there isn't any wiggle room side to side. So I think that there's value to getting the muscle to just calm down by incorporating inhibitory pressure plus some rotation of the pelvis. I think we're still having a good conversation with it. But the really good thing, body mechanics wise, is if I'm applying pressure here and they roll toward me, now I have an actual better angle on it. My hands can stay more lined up, I can protect my wrists, and I have them turn toward me, and now I'm getting more compression on other parts of psoas, but maybe even a deeper application. But they're in control. And then I have them go the opposite way. And there I have to be a bit more cautious with my hands, but maybe I get something more on the side of it. This is a big muscle. So just like finding spots in upper trap, is it the squeeze that works? Is it the direct compression part that works? Is it the stretch that works? You have to think multidimensionally with all of this. So compression plus the rotation of the pelvis lets you and them figure out which one of those is going to be the best. But with that, easiest on you body mechanics wise. And then you can pick, especially when it's intense, and sometimes this can be quite intense, they can pick which position is most comfortable, and there's your positional release. They hold that position 10, 20 seconds, and then move back to midline, and you can just be like, did that change? If it got better, hooray. This is the one though, when I feel it change in tone, if it's real bad, I do feel this actually kind of just melt. Like if I feel a true muscle release, it tends to be this when it's bad. So typically you'll feel it, but I try to be a bit more ambiguous with clients. I'll say, okay, move back. Did I feel like that changed? Got better? Got worse? Stayed the same? They say, no, that's a lot better. I go, yay.
So look, I'm guessing you're at about a 3 on that compression on the 10.
You gotta be deep.
Oh, you gotta be deep.
Yeah.
So you're like a 6 or 7.
You're going based on the size of the client, that's gonna be the journey. So that's also part of where just getting to the edge of the pelvis and coming in, it keeps you from having to go through the belly. So less pressure usually is required coming over here, but yeah, the amount is tough. And I occasionally feel like when it's too light, but I'm still eliciting that symptom from them, because I've had this case where I'm doing what looks like a psoas release, but my pressure level is not deep enough. And they symptomatically are going like, holy cow, that's it. Is it that my pressure is creating kind of a ripple effect from squashing here and then that squashing into psoas? Maybe. But maybe it's just the lower obliques are angry. And that's fine. Those are the most important things. Ideally, that's where like the whole fix it piece all comes together. If the story ultimately is weak core, tight psoas, weak glutes, if I can release psoas and encourage the glutes to engage and facilitate more, then maybe we can start to get this effect where their core now is more effectively able to engage and start supporting their torso. And the poor erector spinae and spine muscles and psoas aren't working so overtime. But if we can't balance out these relationships, especially when one side is way too short and way too strong, they don't even have that potential. So it ends up, when we practice this, it turns a lot into crooked pelvis, maybe. Let's do the psoas release, see if that made it uncrooked. Still crooked, let's encourage the pelvis to be less crooked. And all the time, if I can, looking to make things more symmetrical. But in this equation, you're gonna always hear me say glute maximus needs to be encouraged to be stronger. So on some level, either it's coaching secondary to the treatment, or it could be during the treatment. A person does not necessarily need to have their leg go all the way down into extension to activate the glutes. It's just, it might be kooky for you to say, we got you, we gotta have you do a butt clench. That's the goal. I want you to activate those glutes. You know, there's no real, for people to understand what you're saying. But they can have their knees flexed like this. I could be inhibiting psoas and saying, all right, try to fire your glutes. And that could be a way to reciprocally inhibit all of this too. So if we couple that, for example, with a person laying in prone, inhibiting the erector spinae and having them lift the opposite leg, that's also encouraging glutes to activate. There's ways that maybe 2 or 3 times in the session, I challenge some muscles to reduce in tone while encouraging, in this case, gluteus maximus to increase in tone. And that's where maybe some magic.